I am Frances Namuganga. I'm the project coordinator for the UMSP Uganda Malaria Surveillance Project, where we do surveillance. I'm going to present about the utility of the Uganda Malaria Surveillance Project Outpatient Malaria Surveillance Network. We have malaria reference centers in 70 facilities across the country. These are all located at outpatient facilities, and they are high volume level 3, level 4 health centers. They are located in 38 districts. 32 of these have paired MRCs and 6 have a single MRC. Of the 6, 3 sites currently have indoor residual spraying ongoing, and 2 sites IRS was recently stopped, while for 1 site, it's in a low endemic setting, and we kept it for that. There is no recent history of IRS. These sites were opened across over the years from 2006 to 2019. In 2019 is when we opened the largest proportion of the sites, which is 46 new sites. We have over 5 million patient visits in this database, and we add about 90,000 observations per month. The map on your right shows you the location of the different sites by region, and also by whether or not the sites have IRS ongoing. So what are the basic principles we use? At these facilities, data is collected at the level of the individual. We use Ministry of Health registers called HMI 001, 002, which is the outpatient register, and we enter the data from the outpatient register into an electronic database done by health information assistants employed by Ministry of Health. We then merge the data into a master database, and then we do cleaning and also standardization of certain key variables. We emphasize data quality, and we also build capacity of the health workers as we implement this project. The advantages of our routine surveillance system compared to DHIS2 is that it allows greater flexibility with analysis. The data is of higher quality, so you can better assess trends in malaria, and you also can evaluate a wider range of malaria metrics. We ensure that the data is of high quality. We do routine data quality assessment and data verifications, where we assess line to line of the variables that have been entered in the master database. We focus on accuracy and completeness. So we verify the variables entered into the master database with what is in the primary source document. We also do what we call a quality control dashboard, where we look at 3 key indicators, that is suspected malaria cases, non-tested, age missing, and village missing. Now we ensure that these are less than 5% per month at each of the sites. This is just a screenshot of that QC dashboard with a selection of the sites that we have there. From late last year, we got a little bit of blips above the 5% in certain facilities, and these were due to stockouts of RDTs, and also we had human resource challenges, especially in the lab. However, those have been rectified since then. What have we seen? What are the successes of the UMSP surveillance network? One, we've noted that over time, we have improved testing rates at these facilities from about 50% to 100%. This has been done by training health workers and encouraging them to adhere to the malaria test and treat policy, and also supplying buffer stock of SCTs and other malaria commodities to ensure that testing is uninterrupted. We've also eliminated prescription of anti-malarials to patients with a negative malaria test result. In the graph on your right, on the x-axis are proportions, and on the y-axis is the month and year of visit. And the red graph shows you the proportion of patients that have been tested negative for malaria that received an anti-malarial. When you see from 2006 to date, that that proportion has gone to near zero, while the proportion of patients with suspected malaria that was tested, which is represented by the blue line, is nearly 100% at all the sites, the 70 sites. We are also working with the Uganda's Division of Health Information to promote data use for decision-making at facilities, one by automating weekly and monthly HMIS reports. We also facilitate the HIS to generate summaries of malaria cases stratified by village at facility level, and this informs their outreaches at facility level. And also we are working on linking the UMSP individual level data to DHIS, which is the national platform for aggregating of routine data. What are the limitations of routine malaria metrics? The routine malaria metrics that have been commonly used have been test positivity rate and total cases of malaria. These are usually derived from aggregate data from DHIS2. And there are some limitations with using these. One is the test positivity rate is just a simple proportion, which is the proportion of those tested that tested positive for malaria. And it is difficult to translate this one into a quantifiable public health measure. It also, when you have changes in malaria incidence incidence of non-malarial febrile illnesses, you may have changes in TPR. This may affect changes in TPR. And also, if you have large changes in malaria burden in a high transmission setting, these will be associated with small changes in TPR and vice versa for low transmission settings. Then the other matrix that is used is total cases of malaria. This is highly dependent on the catchment area and the health seeking behavior of the patients. And it doesn't have a clear denominator, so you cannot easily use it to compare malaria burden in one area versus another. The gold standard of measuring malaria burden is malaria incidence, and this is defined as the number of cases, malaria cases per person per unit time. We have developed a method to systematically estimate malaria incidence using health facility-based surveillance data. The first thing we did is to identify target areas comprised of a few villages around the MRCs. As you saw in our dashboard, one of the indicators that we emphasize during data collection is collecting the village and parish of residence of where patients are coming from. So we use this to identify the target areas, and these are comprised of a few villages across each MRC. And then we've conducted enumeration surveys to estimate the population of each catchment area. And then we've been able to estimate the malaria incidence. On your right is a map. That map shows villages, different villages surrounding the malaria reference center, the tiny dot red, and then that black, the one that is the area that's surrounded by a dark black line is the catchment area for this particular health facility. What have been the successes of this UMSP system? One, we've been able to generate incidents, and we've used this to monitor the trends and the impact of malaria control interventions. We've been able to document the malaria resurgence in IRS districts over year 6 and 7, after year 6 and 7 of sustained IRS, and this is a published paper, and we'll also present some work on this by my colleague. Then we also have the lineup 2 study, which will be presented by my colleague Sam, and these are all based on the UMSP data. The graph below just shows malaria incidence per 1,000 person years from selected target areas around MRCs. This was in 2021, and on your x-axis is malaria. On the x-axis is the sites, and on the y-axis are malaria incidence per 1,000 person years. You notice that the different color codes show the different regions where these sites are located, and you note variability in incidence across, even within the same regions, but even across the different regions. You have areas that have very low malaria incidence and those that have very high malaria incidence, like in Acholi, which is the black area. We've also been able to do dissemination of our results through monthly reports and quarterly reports. Monthly reports are shared internally, but also with the health facility staff and the district health teams. And we also share the quarterly reports to the same group, but also other implementing partners to use this data. We've worked with the Ministry of Health to see how we can redesign these reports and better fulfill their their needs as NMCD. We've also published a number of papers, including the impact of stopping and starting IRS, the IRS resurgence paper, and one on impact of COVID-19 on malaria indicators. In summary, the UMSP network highlights the importance of continuous surveillance that one, provides longitudinal measures of malaria burden, two, acts as a platform to monitor the impact of malaria control interventions at population level, and it's also a critical source of information for malaria upsurges and epidemics. This also helps inform response, and it also has provided a platform for other forms of surveillance for malaria and non-malarial illnesses. An example is that we are currently working on a malaria molecular surveillance study that is based and will be happening at these UMSP sites. We also have COVID surveillance going on, and we've also had acute febrile illness surveillance going on at these sites. The policy implications of our work is that this enhanced system has one, generated high quality data that complements the aggregate data from DHIS2, and it has also provided a rich platform to monitor trends of malaria burden and also quantify impact of malaria control interventions. We've noted that there is a need to tap into other opportunities to promote the utility of this system, and also disseminate this much more widely, utilize the MRC platform also to evaluate other novel malaria control interventions in Uganda. Thank you very much.